Hi everybody and welcome to this evening's webinar. Apologies for the late start. We had a few IT issues. Unfortunately, those IT issues are ongoing and Dr. Gaughan can't actually hear me, but she is going to proceed with the presentation anyway, and we are going to go with the Q&A at the end of the session. So if you want to send in questions throughout the presentation, you can through the chat function or the Q&A box, and we'll try and get as many questions answered at the end as possible. So thank you very much for joining us. Thank you very much, Dr. Gaughan, for taking the time this evening to do this for us. We really appreciate it. And with that, I'm going to hand you over to Dr. Gaughan.
Hi everyone, good evening. I was doing some lip reading there with Aoife because unfortunately the sound of my laptop seems to have just gone just now and I can't recover it, but we're going to use the chat function. I think everyone can hear me very well, and if there's any issues with the presentation or you can't hear me very well, please just let me know. So we're going to start off with a short presentation that I'm going to go through with everyone now. That's great. I think the sound is, you can hear me. It's just anyone trying to say anything to me, I don't think I'll be able to hear is the main problem. So we're going to go ahead with the presentation, and I'm going to talk a little bit about COVID-19 and what we know so far about COVID-19 and people with multiple sclerosis, and then I'll go into the vaccines and what we know about the vaccines and the vaccine information in Ireland to date, and then we'll have time at the end to take some questions that people might have, which I will do my best to answer, but with the caveat that I suppose there's a lot about the vaccines that I won't be able to answer yet, that we mightn't have the information available yet. So I'm just going to start off with the presentation now, and I'm just going to, share my screen 1 second here. Oh, it looks like, Aoife, I amn't allowed to share the screen. So I'm not sure if you can change the permissions just to let me share the screen, if that is possible. It's just saying, oh, that's perfect. Thanks, Aoife. So let me see, we'll go here. And I think everyone can see my screen now, and I'm just going to go from the beginning. Sorry, I just have to look from the beginning button. Okay. So a little bit about multiple sclerosis and COVID-19. COVID-19, also known as SARS-CoV-2, was discovered just over a year ago now, and it's been a long year, I think, for everyone involved. And it has a range of presentations, and we are learning a little bit more about the types of presentations it can cause over the past year. So it can frequently, as we know now, be asymptomatic or have a very mild clinical course, but it can also present with fever. A lot of people report the first symptom that they get is a loss of sense of smell or taste. Some people get a cough. A lot of people experience shortness of breath, chest tightness, chest discomfort, and unfortunately a small number of people who get this infection develop quite severe respiratory distress. And on top of this pattern that we know and we're quite aware of, it can also have cardiac complications, neurological complications, and vascular complications. It has been known to cause things such as stroke, particularly in younger people. It's a very infectious condition, but the majority of cases, particularly in a younger population, are mild, self-limiting, and the majority of people who do get COVID-19 aren't hospitalized. And I think that's important to remember as well. I suppose one of the problems is that it's so infectious, as we know, that when you've a very large number of the population catching a condition, of course, a large number will end up having a serious complication. So how the coronavirus really works and how it's infectious is the spikes really attach themselves to the surface of the host cell, invade the cell, and then replicate. And this can provoke quite a dramatic inflammatory response, and it can be this inflammatory response that causes a lot of the problems. And the early advice for a lot of the population who have another condition would have been to cocoon. to take care, to be careful about your contacts, maybe to stay out of work. That advice has evolved over the past year as we have learned more about the condition, which I'll discuss in a couple of minutes. The original recommendations from a disease-modifying treatment point of view in people with MS are represented quite well here by the group from Barcelona called the ChemCat group, but this is very similar to the advice that was being given internationally. So this looked at what types of drugs in MS seemed to be reasonably safe to start during the pandemic, to continue during the pandemic, and what to do if the patient taking the disease-modifying treatment had a case of COVID-19. Okay, and as you can see, it varied very widely. This advice was published around March or April of last year, and really it generally stands with some exceptions, which again we can go through now. We can go through in a little bit more detail, and if anyone has any questions on, we can go through as well. So what do we know at the moment, and how do we know it more importantly? So we know that the risk factors in the MS population are really very similar to the risk factors in the general population, that age is the biggest risk factor, obesity is a concern, that men seem to do much worse than women, that people who have severe disability, again, tend to do a little bit worse, that those with other comorbidities, so particularly people with high blood pressure, obesity, for example, would tend to do a little bit worse. There is some evidence that people from other ethnic backgrounds, so perhaps people from an Asian background, for example, may do a little bit worse, because there's a lot of debate around this. Because, for example, in India, the rate of coronavirus infection has actually been very low compared to what would be expected for such a large, densely populated country. We do know that socioeconomic status makes a difference, and that's probably partially due to the fact that people who are lower income tend to be working in more at-risk professions and might find it more difficult to cocoon, for example, and are also commonly living in more densely populated areas. So how do we know this information? And I think this is just important to discuss about where the information comes from. And initially, very early, it was coming from single case studies. So if you can see the bottom case study on the left there, it's quite small, but if you can see it, it talks about a severe COVID-19 infection in a patient with multiple sclerosis treated with fingolimod. So that's one case report of one person. But that was quite widely published at the time, but a single case report isn't really the kind of evidence that we're looking for. So what we want is the larger studies. So the Dutch experience, where they followed, I think they had about 90 people who had coronavirus and they reported their outcomes there. There was an Italian case series where they looked at about 800 people, and a large number of that who had MS and coronavirus, and a large number of that population would have been in the north of Italy, which were very bad affected, and they looked at the outcomes there. And we've got the pharmacovigilance case series. So that's data where people are on clinical trials already. So for example, they might be on one of the Ocrevus clinical trials. And those people are followed very carefully. If they get coronavirus, and that data is collected and looked at very carefully. So from case studies and case series, you get a lot of detail, but you can't really extrapolate that to the rest of the population. So here we hear about one person with MS who's on Gilenya who did quite badly, but as we know now, being on Gilenya, it doesn't confer any particular risk or isn't particularly worrying, because now we know about hundreds and hundreds of thousands of people who've had coronavirus and MS, and there isn't any major concern there. So, but when you go to the bigger case series and the bigger case registries, the problem is you get a lot of little bits of information, but you don't have the same detail that you do in the smaller studies. What does the data suggest overall? So it says that in MS and in people on disease-modifying treatment, there isn't really any increased risk of severe COVID-19 infection, but there is possibly an increased risk of hospitalization and more severe infection with rituximab and ocrelizumab. And that's based on a couple of the larger studies, but again, we lack detail. That wasn't borne out in some of the smaller studies, but there did seem to be a slight signal. Now, in these studies, they did try to control for the fact that a lot of the time people who were on rituximab in particular might be an older cohort, might have other comorbidities, and might be slightly more disabled. So they would be at more risk of a more severe outcome anyway. So they did try to control for that in the studies, but we do wonder if that might still be having an impact. So as we've kind of said now, what are the issues with the data? So a lot of the studies weren't certain that the people they were reporting had coronavirus. So what they were doing was asking their patients, do you think you've coronavirus? And some of them were saying, oh, I had a bit of a cough, I had some shortness of breath, I wasn't tested because they're not testing anyone without a fever in my area, but that person might be documented as having coronavirus, even though they mightn't be absolutely sure. In different areas, they were collecting differently. So in some centres, in Iran in particular, one group did a study where they rang 25,000 patients who were on disease-modifying therapies to ask them if they had coronavirus. So that was extremely thorough and very careful, and they individually checked all these 25,000 patients. Whereas in other countries, they were waiting for the patients to contact the centres. The problem with that is that people with mild coronavirus might think, oh, I'm actually fine. The hospitals are very busy. I don't want to bother anyone by telling them. So that means that you're skewing the data towards perhaps the more serious cases. So you have to watch out for that one. Some people might be included in more than one registry, so they're being counted twice. And we don't have that much information. So we might be reporting on somebody with Ocrevus, but they might have only been Ocrevus a month, having previously been on alemtuzumab or cladribine or natalizumab or another therapy. And we don't have all that data. And how people do often depends on where they are. So one study looked at a group in New York and a group in Spain, and they looked at the incidence of infection, and they found that the group in Spain had actually a lower overall infection rate than the group in New York, and that the socioeconomic factors seem to make a bigger difference in New York, partly because in Spain more people were cocooning than they were in New York. So that makes a big difference. The rate of COVID in the country that you're living in makes a huge difference in how likely you are to catch it. So what we're seeing over the last couple of months would be that more patients or more people in general, obviously, are catching COVID over the last probably 6 weeks or so than would have done around March or April last year. So we're seeing higher rates than we would have expected to see. In some countries and some areas in some countries, access to ICU might be challenging. And they might have different religious or cultural differences about who would access ICU, depending on resources, depending on beliefs. And that all is an influence in how people do overall. So we're coming on to the vaccines now, an area that we're generally very excited about and is the one note of positivity that we have at the moment. So I know with vaccines and MS, historically, there has been concerns about safety, but happily now we have a wealth of data, decades of data, suggesting that vaccines are safe in MS. And one of the original concerning studies was in relation to the yellow fever vaccine, a small case series of a few people who seemed to develop some demyelination a short time after receiving the yellow fever vaccine. They've actually looked at a lot of that data since and think that perhaps it wasn't as clear cut as it seemed at the time, and perhaps even the yellow fever vaccine isn't particularly dangerous. We generally tell people to avoid being vaccinated during an active relapse and caution with some live attenuated vaccines. But overall, we would be recommending, as a lot of people would have come to clinic and seen us here with the flu vaccine annually, the pneumococcal vaccine, that we would be recommending vaccination in people that we meet in our clinics who have MS. So how are things going internationally on the vaccine so far? And in the developed world, they're going, I would say, very well. Now, this data is a few days old, and I would say this number is much higher than it was already. And even within Ireland, and I think there might be a perception that we're not necessarily doing that well, but we have about 150,000 people in the country have received the first dose of the vaccine, and the second doses are well underway at the moment. What we need, though, is about 70 to 75% of the population internationally to be vaccinated for us to achieve herd immunity. So as you can imagine, we're a long way away from that at the moment. But what we are going to have, and particularly by the time the vaccine has been offered to a lot of people who are listening tonight, we're going to have a huge amount of information available on the vaccine internationally. So we know that the vaccines are coming. We know that the vaccines work, and the data suggesting that they are safe so far is very strong. And the EMA came out this week suggesting that there's been no deaths in Europe so far post-vaccination. There has been some anaphylaxis, and I think that was seen in the States in particularly, but it's been treated, and there is a monitoring period after vaccination to specifically keep an eye out for that. So I'm going to focus mainly on the vaccines that are available here at the moment, because I can't really talk about the ones that aren't available for a couple of different reasons that we can go into as well. And the two vaccines that are currently available in Ireland have a very similar mechanism of action. They're a very new type of vaccine called a messenger RNA vaccine. And what they have done is that RNA is kind of almost like a little recipe for how the spike protein in the coronavirus, and the spike protein is the part that we spoke about a little bit earlier. If I can get back to that picture, so the spikes. So that RNA is being delivered inside a little pocket of fat inside your body, and it's telling your cells how to make a spike, but it's not infective in any way. And when the other cells in your body, when your immune system sees that little spike, it develops antibodies against that spike. So then when the coronavirus with its spike comes along, your body has already developed antibodies to protect against that spike being able to attach onto the surface of the cell. With the Pfizer vaccine, and some people are concerned that it was done very quickly, but what they actually did was, instead of running the 3 phases that are normally done in the clinical trial, one after the other, they kind of ran them in parallel with very careful monitoring at different parts. And they have published exactly how they did the study, and it's available online, and it's written in quite clear, easy language to understand if anyone wanted to look at that a little bit further in a little bit more detail. I'd like to emphasize the very large number of participants they had in these clinical trials. So as you can see from the table on the right, they had over almost 40,000 people were involved in the clinical trial. Actually, I think slightly over 40,000 people involved, which is a huge number of people who had the vaccine during the very closely monitored clinical trial. They received 2 doses of the vaccine. They were given the vaccine 3 weeks apart, and then they were monitored 7 days after the vaccine. And at 7 days after the vaccine, if you kind of look here, how many people, at least 7 days after the vaccine, how many people developed COVID-19. And as you can see in the treatment group, it was about 8 people, and in the placebo group, 162 people. In the Pfizer vaccine, they started at the age of 16, so it was trials in people over the age of 16, and they're currently running a trial in the 12 to 15-year-old age group. They included people from all ethnicities, and they included people with a lot of other comorbidities, although not multiple sclerosis. The Moderna vaccine is also a messenger RNA vaccine, and it's given very much the same way. The 2 doses again, administered 4 weeks apart, and their data was also excellent. So they looked at the outcomes 14 days after the 2nd dose, and they found that the people with the vaccine, out of almost 15,000, 11 people had developed COVID-19. Nobody had severe COVID-19, but in the placebo group, 185 developed COVID-19 and 30 had quite severe COVID-19. So both vaccines have about a 95% efficacy rate. The Moderna vaccine was done in the over 18s. Sorry, man. For some reason I can't go forward. There we go. So they're the two vaccines that are available at the moment, the Pfizer and the Moderna. The Pfizer has to be stored in initially when it arrives in a -80 fridge, and there are strict rules around thawing and then delivery of the vaccine and the timeline that you have there. The Moderna vaccine is a little bit easier. It's in a -20 fridge, and there are many more of those available in the -80 fridges. But the vaccine that we've heard a lot about lately is the Oxford Astrazeneca vaccine. And it can be stored in a normal fridge, which makes things much easier for people planning the delivery of the vaccine and people actually delivering the vaccine. So it's more similar to a traditional vaccine in that it uses a viral vector, so a little virus, to an inactivated chimpanzee adenovirus. So that cause a respiratory tract infection, but the virus has been essentially switched off. It doesn't work as a virus anymore. It can't replicate in your body, and it delivers a little bit again of the protein, causing the antibodies to develop. It's also 2 doses, but as you might have heard in the media lately, there's been a lot of difficulties in relation to when this vaccine is going to be available. And it looks like we're not going to get it when we originally expected to get it. And that's a bit of a blow, because I think it was this vaccine that was planned to be delivered to a very large number of the population. It's a non-profit vaccine, and there are plans to deliver this vaccine to low-income countries at a very low cost. It's similar to the Johnson & Johnson vaccine, but the Johnson & Johnson vaccine is a single-dose vaccine, and we're not quite ready yet. The Oxford AstraZeneca vaccine is considered to be probably about 70% effective compared to the 95% efficacy rates in the first two, the Moderna and the Pfizer vaccine. But actually 70% is considered pretty good for a vaccine. The flu vaccine annually is probably in around 50% effective. So 70% is good enough if enough people get vaccinated. And that's the important thing to kind of remember with that one. You might have seen some concerns about, is it effective in the elderly? And it probably is, but the problem was in the trial, in this trial, they only included a small population of people over the age of 65. I think it was only 8% of the total trial numbers were over the age of 65. So they don't have quite the same strength of data that the other 2 studies have. So what we don't know yet is when everyone is going to be vaccinated. We roughly know which order, which I'll go into in a second with data from the HSE, but individually we can't really tell. We don't know which vaccine people are going to be offered, individuals are going to be offered. We don't know enough about the degree of protection against the variants, although both the Oxford and the Pfizer vaccine have come up with kind of reassuring data in relation to that. Most importantly, I suppose, we don't know how much the vaccines prevent transmission. Now, there is a lot of logic to the fact that if you're not asymptomatic, you're going to transmit less, but you may still transmit. So even after you're vaccinated, the advice is certainly going to be to continue with precautions, particularly around vulnerable people. And we're still awaiting safety data for children, but I expect the 12 to 15-year-old data would be out pretty quickly. So this is directly from the HSE, the provisional order in which people in Ireland will be vaccinated against COVID-19. So the first 2 groups are in the process essentially of getting their second dose. And they're also in parallel hoping to start vaccinating group 3, and they're going to do that in order. I think over 85s, then over 80s, then over 75s, etc. I think it is expected that probably people with MS may be in group 7, but I don't think that is definitive as yet. Particularly since the evidence really demonstrates that there isn't a particular increased risk for people with MS unless you have other comorbidities or unless you fall into maybe an older age group, for example. And people might find that they're actually already vaccinated because they're in a higher group. Regarding pregnancy, overall, the HSE are advising that you probably should get vaccinated if you're pregnant, and the RCPI have published this leaflet to kind of help with this decision if you're considering that. And overall, they're saying you shouldn't really get the vaccine if you're within the first 14 weeks of pregnancy or after week 34. That if you are getting vaccinated, you don't need to wait any period of time before you become pregnant. If you have the first dose and become pregnant, wait till after 14 weeks to get the second dose, but discuss it with your GP and or your obstetrician and have a think about things overall. There is perhaps, if you're pregnant, slightly increased risk when you're later in your pregnancy, and there has been some preterm deliveries in people who are pregnant who have developed COVID-19. So what are the different MS societies saying about vaccinations so far? They're saying that some disease-modifying treatments, and I'll go on to this in a second, might reduce the effectiveness of the vaccine. They've suggested that it might be advisable to change the MS treatment plan. Probably wouldn't be. They've suggested that reduced response is better than none, so they would still recommend the vaccine. And internationally, between the National MS Society in the US and the MS International Federation have overall recommended, and they've commented specifically again in the Pfizer and the Moderna vaccines, because they're the vaccines that we're currently discussing and that are available and that have been licensed. They've said overall people with MS should go ahead and take the vaccine. Now, regarding individual disease-modifying therapies, there's really no concern with, for example, the interferons, with Tecfidera, with teriflunomide, with ocrelizumab and rituximab, because part of your B cell system is suppressed, it might reduce the response to the vaccine by up to 50%. Now, we're not certain about that, but we think that it probably does. What they have looked at is people who've been on ocrelizumab or rituximab who've had COVID-19 already, and they've checked their blood for antibodies after a period of time, and they seem to have either none or a much lower level than people who are not on these treatments. So I think that's partly where they're getting the information, and I suppose from the science and immunology around it, that it might reduce the response to the vaccine by up to 50%. They would still, however, advise vaccination, even if that's reduced. Fingolimod may slightly reduce the vaccine response. We don't know by how much, and we would suggest certainly not altering your fingolimod treatment, but just going ahead and getting the vaccine. With alemtuzumab and cladribine, they suggest to get the maximum response, maybe wait around 3 months post-treatment for vaccination. The second year of treatment could potentially be delayed for a few months to allow for vaccination. That would have to be discussed very carefully with your team, and it would really depend on the individual circumstances and if you knew when you were likely to be vaccinated. And overall, with treatments like ocrelizumab, alemtuzumab, cladribine, we recommend not being vaccinated for around about 6 weeks before you're treated, if it's your first time for treatment. So where should you get more information? More is great information in MS Ireland and their COVID-19 kind of hub. The MS Trust UK has good information. There's a good podcast on that, Living Well with MS, which goes into vaccines with MS. And I've mentioned to Aoife already that perhaps if needed, I might come back in a couple of months and just update depending on where things are then and if there are other questions at that time. So what I'm going to do is just stop sharing now, and I could see some questions coming in, so I might go back and try and answer some of the questions that people have. If that sounds okay, Aoife, does that sound like something I should do?
Yeah, that'd be great, Maria. Thank you.
My sound is working. I can hear you.
Well, in that case, then we might go back to what we had originally planned.
Super.
Would that be okay? And it might be easier for you than trying to scroll the questions and answer. Is that all right?
Yeah, I might go through just some of the Q&A that came in just for people. Would that be okay?
Yeah, of course.
So I'll just have a look at some of the questions. So somebody's mentioned different vaccines, 90% effective, 70% effective. Can you explain it? So what I would answer to that is that it's interesting that the Moderna and the Pfizer, which are essentially very similar types of vaccines, were developed in the same way, have a similar level of effectiveness, so around 94 and 95%. The Oxford Astrazeneca is a more traditional vaccine, and it's the 70% effectiveness. It's just the amount of antibody response it gets, and it's because it's made in a different way. So probably what we're finding is that these newer vaccines that we're getting are probably going to be the way that vaccines continue to be developed in the future, because that's the kind of better response that they can get. But it does seem to certainly be that vaccines that were made in a similar way, that have a similar mechanism of action, have a similar effectiveness. Whereas the more traditional vaccines have this kind of traditional vaccine response that we would expect. They're more about 70% effective. So is it safe to take the COVID vaccine if you're taking rebif? We would say yes. So it would be in the group of the interferons, and there'd be no concerns. Sorry, I'm just having a quick look. So someone has asked about is being disabled, does it make you more susceptible to catching COVID-19? And it's the data, and I hope I haven't misspoke at any point. I think overall it's not that you're more likely to catch it, but you are more likely to have a severe clinical course. And we see that across the board. It doesn't really matter what the reason for the disability is or for the difficulties that you're having is, but if you do have disability for any reason, you seem to be more susceptible to more severe COVID infection, and that might be to do with the reserves your body has with recovering. The exception to that, I would say, seems to be children and teenagers, that even children who might have quite significant disability, we haven't seen the rates of severe COVID infection I think we might have been expecting. Is the Oxford vaccine egg-based? I'm not 100% sure. I don't believe so, but I'm not 100% sure. But from reading the HSE data, even if you have a history of allergy, and I would discuss this with your allergy specialist, they are still suggesting that overall you probably should be vaccinated. But if you have a history of allergy, that is a discussion you should clarify further with your GP and allergy specialist. And they are suggesting for a group that might have a history of allergy in the past, a longer period of monitoring. So the standard period of monitoring is that after you get the vaccine, you sit in a room for 15 minutes and somebody keeps an eye on you. And I think if you have a history of any kind of allergy at all, it's about half an hour is what they're recommending. Someone's asking as well, will you be given a choice of vaccine? And I believe the answer to that is no. And I would say just whatever vaccine you're offered, grab it with both hands and take it as quickly as you possibly can, depending obviously on your circumstances. I think what's going to matter more than anything else isn't really the vaccine that you get, it's going to be the number of people that are vaccinated. So overall in the general population, I think just if you've any influence over family and friends and everyone else around you, just encouraging vaccination, and that'll be more helpful than the individual vaccines. Someone else is asking a similar question about, given that the messenger RNA vaccines seem to be a bit more effective, are they going to be given to people on DMTs that reduce efficacy? The answer is probably not. They're probably not going to individually do it like that. It would be quite challenging to do that, and we don't have an evidence base for that either. But again, it would be the more people in the community that are vaccinated as quickly as possible, the better for everyone in the population. Someone's asking regarding natalizumab, there aren't really any concerns that you should mount a good response. If you're on natalizumab, you should mount a proper response. And another person has asked the same question. Sorry, someone's asking, sorry now, this is just me reading along the slide. Someone's asking what would be the impact if there weren't enough vaccines to get the second dose, and I think that question came in earlier on in the week as well, Aoife, about like what happens if regarding the second dose. So at the moment, the HSE is planning to give 2 doses to everyone. So it's not like the UK where they're planning on giving 1 dose to as many people as possible and then seeing what they're going to do after that. We're planning to give 2 doses to everyone. There is a possibility that the second dose could, of course, be delayed. Although I think so far they've been pretty much on schedule. But the Moderna vaccine did have some evidence that they had a subgroup of people. Most of the people in their clinical trial got the second dose of the vaccine at 4 weeks, but a smaller group of people got it at 12 weeks after their first dose. And actually, the group that got it at 12 weeks after the first dose seemed to mount a really good antibody response, perhaps even better than the group that got it at 4 weeks. So I think that it will probably be a bit frustrating if your second dose is delayed, because you're going to want to be as protected as you possibly can be, as quick as you can possibly be. But I think in the long term, I don't think it should make any major difference to how you do overall. And regarding the second dose as well, the Israel data is supporting the fact that everyone should get a second dose of the treatment, because what they saw is that they didn't see a real change in the number of coronavirus infections until about a week or so after people had the second dose of the vaccine. Someone's asking as well, do I think mRNA therapy will become more common now that vaccines based on the technology have been approved? Yes, I do. I think it's a really exciting area. There's some interesting work being done in animal models of MS, but I think it's very early stage. Someone's asking about Tecfidera. There's no concern about Tecfidera. And sorry, were there any MS patients in the trials? As far as I know, generally not, certainly not deliberately. There were people with a lot of comorbidities who did heart problems, stroke, diabetes, all sorts of things, but I think generally they didn't look at people with MS in particular. And sorry, Aoife, do you want to go through some of the questions maybe and ask me as well that you might have there that I haven't addressed?
No problem. Well, some were emailed in, of course, earlier in the week as well. So we'll just, it's nice to, I suppose, make sure that we answer some of those as well for people who aren't able to make the live event. We definitely had some questions around the vaccine and whether or not you can transmit. So once somebody has the vaccine, they themselves have an immunity to it, but they can still transmit it to another person.
So I think we don't know that you can't transmit it to another person. So we just don't have data about transmission as yet. So I was lucky enough to have my second dose of the vaccine today. I will continue to be very careful, and I won't be in contact with other people. I would be nervous about being in contact with other people at the moment still, so I'll continue to mask, and I won't assume that I can't transmit it, even if I don't get a severe case of it as yet. Like, I think the data will support that you're much less likely to transmit it, but we don't have the data yet. So I think the advice is just to be careful, and I think that reflects a question that came in during the week, Eva, that we kind of had discussed about, someone was saying if their carer is vaccinated, can they transmit it still? And the answer is they can. They're probably a lot less likely to, but we don't have that data. So precautions should still be taken as much as possible,
Yeah, just err on the side of caution, I suppose, is the best thing to do in that.
Absolutely, yeah. We just don't have any evidence yet. Yeah.
And in relation to the likes of B-cell therapies like rituximab and ocrelizumab, people who have planned doses now in the next few months, I suppose there's a question for them in relation to the timing of the vaccine and whether they should maybe delay their infusion, whether there's a kind of a specific amount of time that will be kind of safe in which to do that. So could you maybe discuss that?
So I will, and there's a couple of different parts to that question. So one of the things is about delaying the dose, and what the ABN, the Association of British Neurologists, have come together, and there's been a lot of thinking about this, but overall the impression is if you're already on ocrelizumab and rituximab, there isn't really any benefit in delaying treatment to get the vaccine, because you might have to delay it 6 months, and by the time your B cells, it could be 9 months, by the time your B cells repopulate, you're putting yourself at a huge risk from an MS point of view then. So that delaying to get the vaccine is probably not a good idea. And we're recommending against that if you're already on the treatment, because the treatment has already kind of done what it's going to do. I suppose the other part to that question though is like, so what if you're scheduled for, you're going to get the vaccine in July, but your ocrelizumab or rituximab is scheduled in July. So what should you do then? And ideally, we would say to keep about 6 weeks between getting the vaccines. And that's tricky. And that's really a matter of timing. And I think that we can't really have those discussions until we know when individuals are going to be vaccinated. And we don't have good information about that yet. So I think you'll be working closely with your MS team around the timing of that. But say, for example, in March or April, if you find out that you're due to get vaccinated in July, but your treatment is in July, perhaps then your treatment could be delayed till August, the beginning of September, until you get your 2 doses. So in that case, I think delaying would be appropriate. But I think delaying to try and get your immune system to recover so that you respond to the vaccine better would not be what we'd be recommending, because I think that'd be kind of a risky thing to do. There is also the possibility that people who are on these treatments will actually mount a pretty good antibody response. Maybe not as good as I would, because I'm not on one of these treatments, but maybe good enough to protect them, you know. So that's yeah, that's why we're saying that. The advice is a little bit different than if you're due your first dose of ocrelizumab or rituximab. If you haven't had this treatment before, what should you do then? And I think that's a bit of a discussion to have with your neurologist and your nurse specialist as well. That if their treatments are being suggested for you, that if you've recently had a clinical relapse, you've got activity in your MRI scan, you're not on anything that's controlling these at the moment, then it would probably be more important and more relevant to you to get the MS under control, because that would probably be a bigger risk to you than not having as good a response as you could possibly have to the COVID vaccine. But it's a very individual decision. Okay, so that, I think in that specific case where you're starting one of these treatments, I think discuss that with your neurologist and your nurse specialist.
Okay, thank you. We did have an email in relation to, it was somebody who they're on an MS medication and they felt very stable and they're considering coming off of it at the minute, just stopping it in order to, because of the pandemic and because of the vaccines. What kind of advice would you give somebody who's thinking along those lines?
Please don't do that. Would be our overall advice. Would be, please don't do that. You know, now you know, just we recommend not doing that. It depends on the medication you're on, but some of the medications, if you stop them, you're at risk of quite a dramatic rebound, you know, so that you actually, one or two of the medications, your MS can escalate and can worsen quite quickly in 2 or 3 months after stopping the treatment. So we would recommend against that. Like, obviously, I think if you're thinking along those lines, I think again, and I don't want to put it back, but I think you need to talk about the individual treatment. But as we've discussed, most of the treatments that people with MS are on, the majority of them, there's no concern about the vaccine response. You're going to mount an absolutely fine antibody response to the vaccine. So you don't need to even think about stopping. And it generally is just the risk with the MS is probably greater than the risk of the COVID vaccine. And that's what we're seeing internationally. The risk is not particularly high, of course, depending on other comorbidities.
We had another email in from an individual who is living with MS, who actually contracted COVID-19, and they were wondering, should they have the vaccine when it becomes available?
Super questions, great question. And the advice is yes. So that person probably has some protection from COVID-19, but we don't know how long that protection that they've had is going to last. And overall, the recommendation would be that if you've had COVID-19, you should still get the vaccine. The caveat to that would be that you should wait 4 weeks after you've had the infection, and you should make sure you're fully recovered. So you wouldn't want to vaccinate somebody who's currently got COVID, who's currently unwell, or somebody who's a fever for another reason. So for example, if you've got quite a nasty urinary tract infection and you're feeling quite unwell, it's probably not the best time to get a vaccine either. And so currently unwell for any other reason isn't a good time to get a vaccine. But if you've had COVID-19, yes, you should still get the vaccine overall, even though you probably still have some protection. But you should wait for 4 weeks after the infection has occurred.
That's very good advice. We did have another email in from somebody who they are due to have their infusion in the coming months, and they are concerned about the level that I suppose the numbers at the moment, and they are concerned about going into the hospital for a full day, or for part of a day even, I suppose, just to broaden that out for more people. Can you talk to us about kind of the level of effort, I suppose, that's gone in from the medical community to ensure that like the likes of infusion wards are safe spaces for people to receive their medication at this
Yeah. And I would say they largely are. And I think the infusion suites in most hospitals are in quite separate areas and well away from areas of clinical care. In most hospitals, patients with COVID-19 are kind of what we call cohorted. They're kept in the same wards, separate from the other patients. People will have heard about hospital outbreaks though, which makes everyone nervous. But that would be much more likely to occur if someone was an inpatient in hospital for a long period of time and had a high level of care. So if you're in hospital, if you're hospitalized and you're unwell and you need a lot of help, you're going to be in contact with a lot more people. And then the risk of COVID-19, that's where most of those outbreaks occur. Someone coming in for the day for the infusion suite, there'll be hand hygiene in the way in. You'll probably come into the hospital, and some people who've been in for outpatient appointments lately might be like, things look kind of actually normal, obviously very safe, but it's not the frantic panic, scenes that we saw in Italy that some people might be imagining. There's nobody lying in the corridors. That generally within the infusion suite, you may not be 2 meters apart, but everyone is masked. That the only person you're really in contact with is the person who might be cannulating you and commencing the infusion. And you're not going to be in very close contact with anyone for a prolonged period of time. There's very good hand hygiene, and overall they're very safe. And I haven't heard of anyone who has contracted COVID-19 who's been attending for an infusion. And I would say overall that it seems to be a safe thing to do, and it is possible to minimize contact within the hospital as much as possible. Okay. So I would encourage you to come. I would encourage you to come.
So it seems to be, business as usual to a large degree then for people with MS, and that, regardless of what treatment you're on for MS, the vaccines are still being recommended at the moment. So I suppose a final question that was emailed in, because I don't want to take up too much of your time, would be, what can people do to make sure that they're in the best shape possible to have their vaccine, to make sure that there's no delays? So what can people do for themselves, I suppose, at this point, to make sure that it's plain sailing over the next few months?
So really kind of just to mind yourselves as well as you can. And I do think, and I haven't mentioned it so far, but I think it's an important thing to mention, is that one of the issues we have seen a little bit over the past year is that people probably haven't been out and about as much as they would normally, and they get a little bit deconditioned. And even people who would be out at work, just working from home. So a lot of people are coming in telling us, I don't feel as fit as I was a year ago. My back is quite sore, my neck is quite sore. They're just sitting more and they don't have as much incidental movement. So while staying safe, if you can just try and maintain your mobility and your fitness and in your mental well-being as much as you can, avoiding infection in general, but taking normal precautions as much as you can. And the hard thing to do, I suppose, for everyone is try to be careful about consumption of media, and news media in particular. That certainly I find sometimes the days when I read more, I'm a little bit more anxious about everything. So trying to minimize how much you're taking in, and just keeping yourself well and healthy in general. Particularly if you do have some mobility difficulties, that you do want to be able to maintain a little bit of fitness and condition they have. And I know even through the MS Society, people have been accessing physiotherapy and other things like that. I know the MS Trust UK has had Mr. Motivator doing exercise classes online for people, but just anything that you can do just to keep yourself as fit and well as possible, that you're in good shape for the vaccine. And I think if you do still have concerns or questions, do talk to your treating team. Some teams might differ slightly in the advice that they give, and I think that's normal at the moment, because there is a little bit of I suppose different information coming from different areas, because we don't have enough evidence yet. But happily, with Israel having vaccinated so many of their populations, with the clinical trials still going, we're getting more and more information all the time. And by the time the vast majority of you are vaccinated, we will have a lot of data. We'll have a lot more information. And like we said, we might have a quick catch up in a couple of months' time again when we're getting kind of closer to that vaccination time. And we can talk maybe about the vaccines that are likely to be available then, if that's something that people are looking for. I might have a quick look at the Q&A in case there's any questions, Aoife, that I'm not going to, I think, get to all of them. Somebody's asking about the cytokine response in COVID-19. So at the very beginning, as I mentioned, it's a big inflammation. And some people have said, well, does the fact that I'm on a disease-modifying treatment help this? And that's one of the theories that we've had, and we don't really know. And generally, at the very early stage of the pandemic, there was a bit of research into that. And fingolimod was in one research trial, interference and inhaled interference were looked at in another trial. And it is possible, but I think it's hard to be certain about that. I think I might have missed one or two questions, sorry.
There's some in the chat as well, Maria. I might just ask. Some people were wondering about what the advice on vitamin D is at the moment.
So yeah, there's very interesting data on vitamin D, and maybe that's another reason that the MS population are doing reasonably well, is that a lot of people with MS are on supplemental vitamin D already. Now, the data on vitamin D internationally is small, but there was a couple of studies that have suggested that people who've done worse, who've been hospitalized, so they compared hospitalized groups of patients and who went to ICU who didn't, and there was some suggestion that people who had lower levels of vitamin D were more likely to go to ICU, for example. That's a tricky one though, because if you already have been unwell, if you've got other comorbidities, maybe you weren't going outside as much, so maybe your vitamin D level is naturally lower. So it's difficult to be sure, but I think being on vitamin D is a good idea. Someone is just concerned about the fact that they feel that the clinical trials skipped the animal stage of the trials, but I suppose they didn't really skip it. They were building in a technology that they already have. So they're using vaccines. So the vaccines that they developed, the Pfizer and the Moderna vaccines in particular, are almost exactly the same as vaccines that they've been developing for Ebola and other clinical conditions over the last few years. So they're using a technology, they're using a type of vaccine that they have, and they're changing it very slightly. So I think there have been those kind of stage of trials, but in the past, they're kind of beyond the animal trial section now, because they know that using these kind of vaccines with a little bit of RNA inside the lipid particle, they know that that is safe in humans because there have been very similar vaccines developed for other clinical conditions. I know there was some concern about the safety. The safety data is there to read for anyone, and it's actually quite reassuring. And I found that even preparing for this talk, I went into a bit more depth than I normally would, and I thought the safety data was pretty good. Yeah, and I'd encourage anyone to read it. Things like a sore arm. I haven't had much of a sore arm so far, but a lot of people have told me they have. Some people get a little bit of chills after the vaccine, feel a little bit unwell. So that seems to be what most people experience. Sorry, was there anything more in the chat?
There was no. I see one particularly interesting here is in relation to somebody who's taken a daily low dose of antibiotic and wondering if that will interfere with the vaccine.
No, that shouldn't interfere with the vaccine at all. That should be absolutely fine. Yeah, and actually, I wouldn't stop their daily low dose of the antibiotic. For example, somebody might be on that to prevent the chance, for example, of getting a urinary tract infection. And it would be important that they don't get a urinary tract infection around the time that they want to get the COVID vaccine for reasons that we spoke about, that you don't want to be sick getting the vaccine, and that's probably not a good idea yet. So that should be absolutely fine.
There's another one here from a person who has had a stem cell transplant and kidney failure as a result of the transplant a year ago for highly active MS, and they're wondering if the vaccine would be safe for them.
Yes, and it's safe and recommended. So once you're a few months post-transplant, I need to double check. I think it's 6, but I need to double check that. You absolutely should be vaccinated. Yeah, safe and recommended given the history there. Yeah, it'd be a good idea to be vaccinated.
We did have a few kind of questions in as well, and I see a couple here as well in relation to carers and where carers fall on the list. And I know that won't be your particular area, Maria, but I suppose people are wondering about, like, you know, the risk that they have in relation to carers, and maybe you might just comment on that.
Yeah, so I'm not sure. I see if I can go back into my PowerPoint again very quickly. I think there's a difference as well between family carers and carers, for example, employed by the HSE. And I know there's been a bit of debate around that. Sorry, I'm just pulling up this list again for a second, Aoife, if you don't mind. So I kind of thought a lot of the carers were perhaps within the frontline healthcare workers group, or perhaps in the key workers. So I would have expected a lot of HSE carers to be vaccinated with it quite quickly. In fact, before the person themselves was vaccinated. I do think it's important they're vaccinated quickly. Family carers, I think, is a little bit more complicated, and might not be done as quickly as that. I think it's important because I do think that as everyone knows, if you are in very close contact with another person regularly for a prolonged period of time, or for perhaps several people, your risk is a little bit higher. Yeah, so I would think it's important that carers would be vaccinated, but I'm not sure regarding the timeline for that. I would hope soon.
And then I might just ask one more question, just we're just after 7 o'clock, and I just be mindful of time. People are asking in both the chat box and the Q&A if the COVID vaccine could cause an MS relapse.
Yeah, it's a very good question, and we think it's very, very unlikely, and we don't have any major concerns about that. I think in one of the clinical trials there was one person who had a transverse myelitis, but actually when you look at the numbers for starters in the trials, we're talking about 30 to 40,000 people. That's very low, and they look very carefully at that. And two things about that would be that COVID-19 itself is associated with getting transverse myelitis. We've seen quite a few case reports of that. So it seems to be lower chance with the vaccine. And another person had a transverse myelitis, but actually they turned out to have a diagnosis of multiple sclerosis already. So there isn't a huge concern about the vaccine triggering an MS relapse, and that's not what we see with other vaccines as well.
So yeah, no, that's wonderful. So look, thank you so much, Dr. Gaughan, for joining us this evening, and being willing to answer so many questions on it. I think you've just given wonderful information, and it's very reassuring, I think, to the MS community to know that things are in very much business as usual, and in relation to the vaccines and everything else, that we can proceed with all of that. So that's wonderful. Thank you so much, and we look forward to having you back in a couple of months.
Sorry about the technical difficulties at the beginning.
Not at all.
Yes.
It could happen to any of us.
Yeah.
Thanks so much, Dr. Gaughan. Much appreciated.
Okay. For your attention tonight. Bye-bye now. Bye-bye.
Bye.